All right. Hello, everyone. Welcome to our Don't Let Eye Disease Steal Your Sight webinar. We just have a little bit of housekeeping to attend to before we start our webinar. So we ask that everyone just mute themselves while the presentation is happening. You can keep your camera off. That will just make the presentation larger on your screen. Don't Let Eye Disease Steal Your Sight with Dr. Geis. All right. So Dr. Geis has so much education. He started at the University of Texas Medical Branch, and then he did residency at Northwestern University for ophthalmology in Chicago, and then did a fellowship at Emory University for neuro-ophthalmology right there in Atlanta, right up the way. So we would love to present to you, Dr. Geis, to talk about eye diseases.
All right, so welcome everyone. We're going to get started talking about just kind of like the routine eye exam and the benefit of having an eye exam, even if you think you don't really have any vision problems at all. Just a little bit more about myself. I grew up in South Florida and went to high school there. I went out to college at Baylor in Texas, which is how I ended up in medical school there. And eventually, after my training and a few years in private practice in Atlanta, came back to Florida and joined Florida Healthcare about 26 years ago now. So anyway, so I'm an ophthalmologist, which means I am a surgeon. I'm an MD. I treat medical and surgical diseases of the eye. Ophthalmologists in general don't do routine eye exams. We generally don't do glasses and contacts. That's kind of not the scope of our practice. We're more treating disease. Optometrists generally are the ones who do routine exams and glasses and contacts. And if they find some pathology on that exam, if they find something that needs some medical or surgical attention, then they will often refer the patient to an ophthalmologist. So a lot of the routine eye care, particularly beginning in the age of our commercial insurance population, people generally under 65, that oftentimes begins in an optometrist's office. And so if you go see an optometrist just for a routine eye exam, they're going to check your vision, both usually distance and near. As we get older, we all start to lose our close-up vision. They're going to do a refraction for glasses. And of course, that's only if they're needed. And I put a little star by the if needed, because I'm going to come back to that in a minute. They're going to check your intraocular pressure, your eye pressure, and that's a glaucoma screening test. And we're going to talk a bit about glaucoma. And then they're going to examine the eye for any other signs of disease. Now, going back to the glasses thing, I just want to make a point, because I think this is a common misconception. People oftentimes feel that if they need glasses, their eyes aren't healthy. Well, that's not the case at all. Very important to understand. Needing glasses just means needing glasses. It doesn't mean you have any eye disease. You might be nearsighted. You need glasses, for distance vision by the time you're in your teens. You might be farsighted. Maybe you get away with not needing glasses until you're in your 40s or so, like me, and then your arms are not long enough anymore, and you start needing a little help with reading. And eventually, if you're like me, you need a little help with distance as well. Does not mean your eyes aren't healthy. Next slide there, if you will, Brittany. So many of the things that can be picked up on a routine eye exam, even in a patient who doesn't have any symptoms, glaucoma, cataracts, these are the big five for us probably. Glaucoma, cataracts, diabetic eye disease, dry eyes, usually symptomatic, and macular degeneration. I starred that one because we're not going to really talk about that, because again, that's typically a condition in the older population. And this talk is geared more towards people under 65. Next one. So just a quick anatomy of the eye. This is a cross section through the eyeball, front to back, left to right. The front part of the eyeball is the cornea. That's the clear part. Behind that, you've got the iris. That's the colored part with the hole in the middle. The hole is the pupil. Right behind that is the lens of the eye. That's what gets cloudy when people start getting cataract formation. Behind that, the rest of the eye is a big hollow ball. It's lined with the retina. That's the yellow semicircular line there. And it's filled with this glob of jelly called the vitreous. And in back of the eye is the optic nerve. That's the nerve that connects the eyeball with your brain. It sends a message from your retina, which is like the film in your camera, to the brain, tells your brain what your eyeball is looking at. Next slide. So close-up picture of an eye, this is what we see when we're examining a patient in the office, and we're looking at all parts of the eye individually, the lids and the lashes, the oil glands in the lid, the conjunctiva, that's the white part of the eye, the cornea, the clear part, all the different parts of the front of the eye, and we examine them very closely under very high magnification. Next slide. And then we'll do a dilated eye exam. We'll dilate the pupils with some eye drops so that we can look into the back of the eye. And this is exactly what we see when we're looking in the back of the eye. This is the retina. It has blood vessels that come in through the optic nerve. You see the optic nerve, that's the little circular orange thing there on the left side. Blood vessels enter the eye and spread out throughout the retina to give blood flow to the retina. And we're going to talk about that a little bit when we get to our little diabetes section. But this is a normal back of the eyeball, retina, optic nerve, blood vessels. Next one. So here's a patient that they've never had an eye exam. This is what it looks like. You're leaning forward into this little thing called the slit lamp. And the doctor on the other side has some little oculars, little microscopic thing that magnifies the view. And we're looking at all parts of the eye. And you can see this patient's enjoying having her eye exam because she has that little smile on her face. All right, next one. And this is how we test for glaucoma. I know this looks a little creepy, but we put some numbing drops in the eye, and this little meter that we touch to the eye helps us measure the pressure inside the eye. And if the pressure is above the normal range, that's usually about 10 to 20. If the pressure is above the normal range, then that can cause optic nerve damage, and that's glaucoma. So if we go to the next slide, we're going to look at some pictures of optic nerves. On the left, you've got a normal optic nerve. That's the round circle with the blood vessels entering and spreading out through the retina. And on the left is the optic nerve of someone who has glaucoma. Now, without going into too much anatomic detail, you can notice perhaps that the glaucoma optic nerve has a big pale part right in the center of it. That's nerve damage. That's a nerve that's not working well in connecting what the eyeball is seeing with the brain. So the eyeball might see everything just fine, but because the nerve that tells your brain about it is damaged, your brain's not getting the message. We'll move on. So glaucoma typically starts in a much younger age than people think. People think this is a disease of older folks. Well, it's generally actually starts in your 40s and 50s, oftentimes later, but many times this is detectable early. It starts off in an earlier age, and early on, there's no symptoms at all. You cannot feel this. This gives you no sensation. It doesn't affect the vision at all until a disease is really more moderately advanced. So there's no signs whatsoever that you have glaucoma until you've got it pretty bad, which is, again, that underscores the reason for having an exam to detect in the early stages before you get to the advanced stages where you've got vision loss that's not coming back. Any vision that you lose to glaucoma is irreversibly gone. And on the pictures on the left side of your screen there, you see a photograph of some cars. And you notice that's a normal picture. The next one down, you might notice that there's some little patchy, blotchy areas in the periphery of that picture. That's the vision loss that starts to develop as glaucoma gets more progressed, more advanced. Little patchy areas of loss in the periphery of the vision. People aren't always really sensitive to this, and you might not even notice this. Only when the disease gets more advanced, quite advanced actually, much further along than we like to see, is when you really start to lose that peripheral vision, and all you're left with is a sort of a keyhole vision in the center of the vision, and that's very advanced. So that's when people really start to realize, hey, I've got a problem here. This is advanced glaucoma. Early detection, just a routine exam with your optometrist can help detect this long before it ever gets this bad. Treatment for glaucoma is to lower the pressure inside the eye, typically with eye drops. We also have laser procedures and even surgical procedures that we can do to lower the pressure in the eye to try to prevent glaucoma from getting this bad. We'll move on. So, cataract. Cataract is when the lens in your eye gets cloudy. And this is a normal thing that occurs with aging, and generally also older folks, but not necessarily. Probably about 20% of patients having cataract surgery are under 65. Because for whatever reason, diabetics tend to get cataracts at a younger age. There's a familial link. But the general thing is a noticeable decrease in the vision, either blurry or hazy. You might need to be getting your glasses updated every 6 or 8 months, which kind of is a lot more frequent than that should be happening. You may have some halos around oncoming headlights, or some glare from oncoming headlights. That's a common symptom in cataracts that are maybe even quite mild, but people will notice some halos and some glare. So in the next slide, we've got a couple pictures of cataracts. And the one on the right is a typical cataract. Patchy, you see, with this dilated pupil, the lens of the eye should be black. You should not see the lens of the eye at all. Light should pass right through it, but you see that those patchy focal little spoke-like opacities. This is what causes that blurring of vision. This is what causes that dispersion of light, and that glare and the halos and things like that. The picture on the left is a really, really significant cataract. We like to see patients before they get to this point. This person can't see their hand in front of their face probably, so don't let it get that bad. Treatment for cataracts is surgery. We go inside the eye, we physically remove that lens, and we replace it with a little plastic lens implant. Stays in the eye forever. Very effective surgery, very, very good results, very, very low complication rate. But something that is worth checking for if you're feeling like your vision's not quite as good as it should be. Might be just you need some glasses, but it might be you have something else going on like cataract. We'll go to the next slide. So we're going to talk about diabetic retinopathy or diabetic eye disease. Florida Healthcare has a lot of diabetic members. This organization is generally very, very good at getting our diabetics under good control. Getting their A1C down below 7 so that they help avoid the development of all those ugly things that diabetes can cause. Diabetic retinopathy, diabetic eye disease, is the #1 cause of legal blindness in this country in people under 65. And over 65, it's number 3, macular degeneration is #1. But the development of this diabetic eye disease is related to how long you've been diabetic, and even more so, how well controlled your diabetes is. You are far less likely to develop diabetic eye disease and basically all of the other ugly things as well if your A1C is typically below 7. So that's the importance of keeping diabetes under control, because the development of that retinopathy, that diabetic retina disease, is largely preventable. It's also treatable, especially if detected early. Our treatments for diabetic eye disease work much better at preventing severe vision loss than they do at getting back vision that's been lost already. So we're going to look at the next slide, and we're going to have 2 pictures. One on the left, another picture of a normal retina. The optic nerve is on the right side. This is a right eye this time. And you see the retina there and the blood vessels. And if you look at the one on the right side, the diabetic retina, obviously this is a completely different picture. You've got little hemorrhages all over the retina in the back of the eye. These are all little broken capillary blood vessels that bleed into the retina, and they don't come back. Once you get that hemorrhage, you've got an area of your retina that no longer has good blood flow. And this person has a lot of blotchy hemorrhages in the retina. So that's a retina that's got bad blood flow. In the center of the retina, you see that creamy star-like stuff coming out of the center of the retina. That's actually fatty deposits that have leaked out of abnormal diabetic capillaries and are leaking into the center of the retina. Now, the retina's got about 10 layers. And they're all supposed to be very compact, and they communicate with each other top to bottom. But if you have all this fluid and leakage and all that fatty junk in your retina, that's going to separate the retinal layers from each other. And that's going to lead to some really bad vision, particularly in the center part here. So this is a pretty significant case of diabetic eye disease. And again, this is the kind of stuff we don't like to see in the office. We like to get the patients far beyond before they get to where they're looking like this, because our treatments, if you go to the next slide, our treatments just don't really work as well when you've already got a lot of bad stuff going on in the back of the eye. With diabetic eye disease, similar to glaucoma, a little bit of diabetic eye disease doesn't really have an impact on their vision. So you don't really feel like you got a problem. But since our treatments work much better in the early stages, we want to get to these patients before they start losing vision. If we see stuff that looks like it might be starting to cause some problems, that's when we want to initiate treatment. So because our treatments work better at preventing vision loss than getting back lost vision. So again, the importance of diabetics, of course, every year, that's a critical thing to get the eyes checked once a year for diabetes to make sure you're not developing problems in the retina in the back of the eye. So the last of the big five, we're just talking about four of them, is dry eyes. This is actually the most common thing we see in ophthalmology practice. Dry eyes are very, very common. Women oftentimes more affected than men. The symptoms: sandy, scratching, itching, burning, little irritation, certainly worse after you've been on the computer all day or reading or driving long distance, simply because you just don't blink as often when you're doing anything that requires real visual attention. You don't blink as frequently. If your eyes are a little dry to start with, they're going to get drier, and you're going to be symptomatic. Blurry vision, progressively worse after you've been on the computer all day. And those sandy, scratchy, itchy, burny things, those get worse as the day goes on as well. There certainly is an environmental component to dry eyes. If you're in a dry or a dusty environment, if you got the ceiling fan on over your bed, you're watching TV in bed at nighttime, got the ceiling fan on, your eyes are going to be a little bit drier because they've been open all day. And then you got the ceiling fan drying out even worse. Winter months, people with a little dry eye condition tend to be more symptomatic because they're in the house with the heat on, and that heated air is much drier than the cooler air from the air conditioning. You go to the drugstore to look for some lubricant drops, and the one I have shown here, this Refresh Optive, it's a good lubricant drop. It's widely available. But you go to the drugstore, you'll see a rack of 50 different types of lubricating drops. Tells you what a common problem this is if there's 50 different brands of something to treat it. So again, most common thing we see, and usually just some lubricant drops a couple of times during the day, if you do have these symptoms, can make you less symptomatic, and can make your vision better, make your eyes feel more comfortable. Red eyes, we see a lot of red eye exams. The majority of them have dry eyes. That's not an infection. They're just red because they're dry. And I usually try to advise people to avoid those gets the red out drops. They just make the red go away. The problem is that the eye is red because it's dry, most likely. So using some lubricant drop can treat the redness and the discomfort that comes with those dry eyes. So I think that's the end. I went through that pretty quick. I tend to talk fast when I'm on these things. So we can open it up to any questions that anyone has. And if you want to chat with Brittany or Carla, if you have any questions, or if you want to unmute, we can go from there.
Awesome. Thank you so much, Dr. Geis, for your expertise there. Just like Dr. Geis said, we've got some time for any questions that you may have. So please add them into the chat and or unmute yourself. We do have one question right now. Are floaters on occasion anything to worry about?
So everybody gets floaters eventually. These are little opacities in the vitreous jelly in the back of the eye, and they develop normally with age. So everybody has them. When the floaters first develop, though, and so no, the short answer to the question is no. Occasional floater is not a problem. Typically, we typically will want to see those patients when the floaters first develop, because the other thing, new floaters in the vision can represent the possible development of a retinal tear, which can lead to a retinal detachment. So when people first develop those floaters, we want to see those patients dilate the eye, look around the back of the eye, make sure that those floaters aren't representative of something bad going on, potential retinal detachment. But 99% of the time, that's not the case. And you've just got some little opacities in the jelly in the back of the eye. And they're annoying, but they're not pathologic. They're not disease.
Okay.
Good question.
Great. Does cataract surgery give you 20/20 vision?
Okay,
or
so
better?
Good question. Potentially. Number one, if there's no other pathology in the eye, if there's no diabetic eye disease or macular degeneration or some other thing that might limit how good the eye can see. When we do cataract surgery, we're taking the lens out of the eye, like I said, and we're putting a new lens back in, and we do some measurements to try to determine the appropriate strength of that lens implant for a given, for a particular patient and for a particular patient's eye. So we try as best we can to eliminate the eyeglass prescription after cataract surgery. And we're always aiming for great distance vision with no glasses. We're pretty good at that. 20/20 perfect actually is kind of hard to get. We get plenty of it, but I tell my patients that 20/30, just below 20/20, we get a lot of that. So we're feeling pretty good if we can get our patients to see 20/30 distance vision with no glasses. If the distance vision is good, probably still going to need some glasses for up close. Although they do make what they call multifocal lenses, which is kind of like a bifocal inside your eye. Insurances don't pay for that, so it's a good bit of extra money out of your pocket if you want to try to have best distance and close-up vision without needing glasses for. But most patients after cataract surgery, maybe not perfect 20/20, but usually pretty darn good.
Awesome. Great. So are you familiar with any eye drops that cause blindness? I think they were maybe on the shelves. Have they been removed?
Yeah.
Are there any brands to avoid maybe?
So they're off the market. This was a lubricant drop that I'd actually never even heard of. Again, there's 50 different ones out there. This was one that I had never even heard. And they had some contamination with some really ugly bacteria. And so people were getting some significant eye infections from using these over-the-counter lubricant drops. The ones that I typically recommend, these are from very reputable, big pharmaceutical companies. They have very tight controls over sterility and production process. So contamination with these ugly bacteria or amoebas, that's unheard of, for the ones that we're recommending. Again, that brand, I can't even think of the name of it now, but I'd never even heard of it before.
Okay. So LASIK, is LASIK worth the investment? Is it risky?
Well, so LASIK surgery is basically surgery to get you out of your glasses. It reshapes the surface of the eye to try to basically make it so that you don't need glasses for your distance vision. It only works for distance vision. So if you're getting into your 40s and starting to need bifocal or some help with up close, it's not going to correct that. So it really, is it worth it? I think if you're in your 20s and 30s, and you still are young enough where you can see up close without needing a bifocal or something, then yeah, it'll get you out of your distance glasses. Particularly, especially if you do water sports, diving, surfing, things like that, where having the glasses on your face is an impediment, then there's a real benefit. Again, just keeping in mind that it's not going to prevent you from getting older. And at some point, you're also going to need some close-up help as well. And so then you're throwing on reading glasses. And since most of us spend most of our time during the day focusing on things that are within 3 feet of ourselves, I think, having perfect distance vision without glasses is maybe actually a little bit overrated. I wish I was a little nearsighted. So I can see up close and work here in the office without needing these. So is it worth it? Yes and no. If I was in my 20s and 30s and I was nearsighted, I might think about it. Get into your 40s, I think it starts to lose its value.
Okay. Is there any condition or any reason why someone may have like watery or swollen eyes, but not necessarily have allergies?
So sure. Again, going back to the dry eye thing, tearing is actually one of the signs that the eyes are dry. That's called reflex tearing. And a lot of patients, their eyes are not well lubricated. They get dry enough where they start actually tearing up. We call that reflex tearing, similar to if I went out outside on a windy day with my eyes open, they'd start tearing up. Well, because the wind makes the eyes dry. Well, a lot of folks whose eyes are a little dry to start with don't need to be outside on a windy day for them to start tearing up. Allergies is another sign of dry, of puffy, watery eyes. But there's a lot of overlap between allergic eyes and dry eyes. A lot of that itching, the tearing. So there's some overlap there. And whoever asked that question, if you're a woman in your 40s or 50s or beyond, I might consider maybe using some lubricant drops to see if that helps with those symptoms.
Okay.
Particularly if there's no other real allergy history.
Okay. Okay. And I wanted to circle back and talk about glaucoma for a second. Is that a family disease? Is that generation?
So glaucoma absolutely has a familial link. If you've got a first degree relative, sibling, parent that has glaucoma, your odds are 3 times greater of developing it yourself. So it absolutely runs in families. But the majority of people that have glaucoma actually don't have a family history. So if there is a family member that has glaucoma, you should definitely be checked for it. But don't think that if you don't have a family member, you're not going to get it. That's not the case at all.
All right. Thank you, everyone. We will
Thank
see you
everybody.
next time. Thank you.
All right. Thanks, Brittany.
Thank you. Bye-bye.